Senior walks into a medical office or a dental office, specialist clinic, lab, or imaging center, and they're there obviously because they need care, or perhaps they're in pain, perhaps worried, and maybe the doctor ordered a test. But before they ever see the doctor, something else often happens. The business system starts by first asking questions for information and signing form after form after form, and at times the patient never really sees those forms, but is still asked to sign. That is where today's episode begins. This Senior Power series is called Don't Pay Medical Bills Blind, but this is not just a series about medical bills. It is about how a patient seeking care can be processed through a business system before care even begins. The senior enters as a patient. The system may process that person as a signer, payer, data source, privacy subject, liability holder, insurance risk, and, at times, a future collection target. That is the frame. And the first lesson is simple. The later bill may not be the beginning of the problem. The later bill may be the result of something that happens earlier, at the front desk, on a tablet, on a signature pad, and inside what someone casually called just paperwork. This series has 3 parts, and this indeed is the first podcast in this series. We entitled it A Trip to the Office, How Medical Care Became a Business Transaction Before Care Begins. And it is a background and history lesson. It explains how the modern medical visit became surrounded by signatures, permissions, notices, obligations, risk transfers before care even starts. Podcast 2 will ask, why am I getting this bill at all? That episode follows what happens after the visit. Coding, insurance processing, denials, provider bills, Medicare summary notices, explanation of benefits, patient portals, third-party billing, and so forth. Podcast 3, we call Make Them Prove It. That episode is the defense method. Very valuable episode. It explains how seniors and families request documents, compare records, demand itemized bill, keep call logs, dispute charges, and so forth. The roadmap is simple. Do not sign blind. Do not pay blind. Make them prove it. That is the Senior Power Framework. And today we start at the beginning. How did a trip to the doctor become a business transaction before care even begins? For many seniors, the old expectation was simple. You went to the doctor because you needed care. You went to the dentist because you had a tooth problem. You went to the hospital because something was serious, and so forth. The focus was supposed to be care, not contracts, not billing codes, not insurance denials, not privacy releases, not collection policies, and not whether a signature on a little electronic pad would later be used against you. But the modern system has changed, and there is no doubt about it. Today, before the patient is treated as a patient, they are often processed as a business file. The office wants to know, who are you? What insurance do you have? What plan are you in? Who gets the bill? Who can receive information? Who can access the portal? Who is financially responsible? Who pays if the insurance denies? Who can be contacted? Who can receive records? Who can be billed? My God, that is not just medicine. That is administration. That is revenue cycle with a strong risk management element. Overall, it is legal positioning. And that is why seniors need a different mindset. Senior comes in thinking, I am here for care, while the system may be thinking, we need signatures, permissions, authorizations, financial responsibility in place before we proceed. That is the gap. And the gap is where seniors can and do get hurt. The front desk used to feel like a place where you checked in. Now in many offices, the front desk is the first business checkpoint. Before seeing the doctor, before speaking to the dentist, before getting that scan or the blood drawn, the patient is asked to complete intake. Sometimes it is paper, sometimes it is a tablet, sometimes it is a kiosk, and sometimes it is a portal link sent before the appointments. And perhaps it is a small electronic signature pad facing the patient at the counter. And that is where the problem begins. The patient may not know what document is on the other side of the signature. The patient doesn't know, perhaps, whether it is a consent to treat, a privacy acknowledgement, a financial responsibility form, Medicare notice, and many, many other things. Okay? So the office may say, just sign here. It's standard. Everyone signs this. Just paperwork. This only says you're responsible for what insurance does not cover. That last sentence is not comforting. It is the beginning of the real question. Why might insurance not cover it? Is a service medically necessary under the plan's rules? Was prior authorization obtained? Is the provider in the network? Truly, things change. Is the service being done too often? Is the coding uncertain? Documentation weak? Is the treatment elective? Or, careful here, experimental, investigational, or not covered for that particular diagnosis? Is the office trying to shift financial risk to the patient before anyone explains why that risk exists? That is why the front desk matters. The front desk is not just for checking. It's perhaps where the business system asks the senior to accept obligations before care begins. While the signature pad is convenient, it can also create a serious power imbalance. The office sees the system, the staff sees the screen. Providers' records hold the document, but the patient may see only a small signature box. That is not enough. A signature is not a small thing. A signature can say, I consent, I acknowledge, I authorize, I accept responsibility, agree to these terms, understand the notice, agree to be billed, agree to pay if the insurance does not. And later, when the senior challenges the bill, the office may say, you signed. That is why just sign here is not just a phrase. It is a pressure point. The senior may feel rushed, or the receptionist may seem impatient, and the office may act like questions are unusual for them. And the senior might think, I don't want to be difficult. That is exactly when the senior needs to be difficult and slow down. Because the issue is not whether the senior is polite. The issue is whether the senior is being asked to accept money risk, care consent, privacy permissions, information sharing, billing exposure, or legal consequences without seeing and understanding the document. Our rule is, do not sign what you cannot see. Not on paper, not on a tablet, not on a pad, and not because everyone signs. If the document matters enough to require your signature, it matters enough for you to read. One of the most dangerous phrases in this whole system is, "It's just paperwork." That phrase is designed to lower resistance. It tells the patient, do not worry, do not ask questions, do not slow down, do not make this awkward, just sign. But paperwork can matter. It can authorize treatment, assign insurance benefits to the provider, make you accept the financial responsibility, even warn that Medicare may not pay. It is really the office's evidence. Some paperwork is necessary, some paperwork will protect you, but some paperwork shifts risk to the patient. And the senior cannot know the difference unless the document is shown. So when the office says it's just paperwork, the answer is, then there should be no problem showing it to me. That is calm, that is reasonable, and it is not rude. It is your control on the situation. The senior does not need to accuse anyone, does not need to raise their voice. The senior only needs to insist on seeing what they are being asked to sign. Because later, if the bill arrives, the office may not say it was just paperwork. The office may say you signed. At first glance, this may sound like a billing issue, but in actuality, it's bigger than that. The documents that they're asking you to sign at the beginning of them caring for you can affect you in at least 4 different areas: money, care itself, privacy, and your rights. Money is the obvious one, but a form may say the patient is responsible for deductibles, co-pays, co-insurance, non-covered services, denied claims, out-of-pocket network charges, collection costs, or balances insurance does not pay. The other, care, is a form which may authorize treatment, procedures, testing, dental work, devices, therapy, lab panels, scans, injections, or follow-up services. In terms of privacy, it involves the medical paperwork, which involves your private health information, releases, their patient portal, which is playing a much bigger role every day, communication permissions, billing, insurers, family contacts, caregivers, and record access. The HIPAA privacy rule gives people rights over their health information, including rights to see and get copies of health records, request corrections, receive notice about how information may be used and shared, and decide whether to give permission for certain uses and disclosures of that information. That means the paperwork is not just financial. It can affect the private information, affect who sees your records and what is shared. Overall rights are another category. Some documents may affect dispute procedures, your ability to dispute procedures. Some may affect your ability to appeal. Others may affect out-of-network billing protections. And some may affect whether the provider later claims the patient agreed to pay. So the patient may just think, I am checking in, but the system may be asking the patient to accept a bundle of financial, medical, privacy, and legal consequences. That is why seniors need to stop treating check-in as a formality. Check-in may be the first stage of the business transaction. So what we're saying is that care has become one of the critical factors in the revenue cycle. And so we have to take a look at and understand how we got here. First of all, we always need to use the famous right words. This is not just paperwork. In the business side of healthcare, this is part of the revenue cycle. That means the system is designed to capture information, verify insurance, obtain authorizations, document consent, codes, use of code services, submission of claims, collection of payments, and so forth. Of course, some of this is necessary. We need to be able to pay the doctors. Hospitals need billing systems to collect. The insurance needs claims in order to do the reimbursement, and records need privacy protections. Therefore, consent matters. But the business process, remember this, is not a neutral process. The business process is designed to protect the provider's ability to get paid. It wants the right insurance information. It wants signatures, authorizations, financial responsibility, language, documentation that supports the billing, records showing that the patients were notified, and so forth. They want to reduce the provider risk. And they want this agreement, obviously, before a dispute begins, which is why seniors need to understand the difference between the clinical relationship and the business relationship. Indeed, the clinician may be caring, the doctor may be good, the dentist may be skilled, and the nurse may be kind, but the business system around them may still be built to protect revenue, shift risk, and collect money. Those two realities can exist at the same time. The medical office may be compassionate in the exam room and aggressive in the business office. The senior has to understand both points of view. For original Medicare, there is a formal notice called the Advanced Beneficiary Notice of Non-Coverage, usually referred to as an ABN. An ABN is used in situations where Medicare payment, listen to this, is expected to be denied. Stop there. That one fact matters. There are official medical forms that exist because payment may be denied. That means some paperwork is not routine, some paperwork is a warning label, and some paperwork is connected as to whether the patient may become responsible. Now, bear me out. This does not mean that every ABN is improper. It doesn't mean every provider using the ABN as an excuse is doing something wrong. But it absolutely means the senior must be told, or the senior must not be told, it's just paperwork. Obviously, if a form exists because Medicare may deny payment, the senior absolutely has a right to ask, what are the exact service or services we are talking about? And why might Medicare deny it? What is its estimated cost? Is there a covered alternative? What happens if I do not receive the service today? Will Medicare still be billed so I have appeal rights? And may I have a copy before signing? Remember this. Those are not rude questions. Those are the questions the form itself should figure in your mind. The senior power line is, if the office knows enough to ask you to accept responsibility, the office knows enough to explain the risk, we hope. Next topic is the out-of-network consent. That is, when a signature by itself can give up your protections. There is another important example of this situation occurring, and that is the out-of-network notice of consent. If a patient is scheduled for out-of-network care, a provider may ask the patient to sign a notice and consent form. Signing that kind of form may mean the patient agrees to receive out-of-network care and gives up protection from unexpected out-of-network bills. This is a biggie. This is not a small thing. It is not harmless paperwork. And its signature can affect what the patient owes, which can go into thousands of dollars. The forms may include an estimate of what out-of-network care might cost, information about surprise billing protections, and the option to give up those protections and pay more for out-of-pocket network care. Again, the lesson is not that every form is bad. The lesson is that some signatures indeed matter. Some signatures can change costs, and that some signatures, most importantly, can give up protections. Those signatures can move the patient into a worse financial position. Hear me out. So when a senior is told, just sign here, the correct question is, am I being asked to give up any billing protection or accept out-of-network charges? That is the kind of question seniors need to become comfortable asking, not because they are suspicious by nature, but because the system itself recognizes that some forms do indeed have consequences. What about the privacy as a patient of your data that these providers now hold? This is not a small question, and this is something that most people don't even consider. Modern medicine is built on data. It includes, and there's going to be a list, your identity, your insurance, your diagnoses, your medications, your test results, your doctors, your pharmacy, your billing history, your caregiver contacts, your portal messages, your imaging, your lab work, your payment information, and your private health information. That is why privacy paperwork matters. Covered entities and business associates are absolutely required to safeguard health information and follow privacy and security requirements. Protected health information includes the information in all of your medical records, those which are present at your insurer, the billing information at the clinics, and most other health information held by those who must follow government rules. So when the senior signs medical office paperwork, they may not only be accepting payment terms, they may be acknowledging or authorizing how information is used, shared, accessed, or communicated. The senior must understand who can receive the information. Can family members receive it? Can a caregiver speak with the office? Can the office leave voicemail? Can the office text? Can it email? And who has portal access? That is access to the provider's website. And how are records requested? How are corrections requested? What information goes to billing vendors? What information goes to insurance? And what is being authorized beyond treatment, payment, and healthcare operations? We're not being paranoid here. Absolutely not. It is about control. Private information is valuable. Health information is extraordinarily sensitive. Billing information can be revealing about a person. A senior should not be rushed through privacy-related paperwork as if it means nothing. The patient is not merely a patient. The patient is also the source of high-quality, sensitive information, and that deserves respect. Dentists are an interesting and special subcase. Because in this case, there are situations when the benefit that you are getting from your insurance becomes the target itself. Okay? So we're going to move from the medical office to the dentist. This example matters because dental care often shows the business logic very, very clearly. So let's go through this. A senior may have dental coverage through a Medicare Advantage plan, a separate dental policy, or another benefit structure. They may go in expecting a cleaning, an exam, an x-ray, or help with one tooth. Then the treatment plan appears. Deep cleaning, scaling and root planing, crowns, implants, bridges, fillings, periodontal maintenance, night guards, fluoride, stage procedures. A plan that starts today, but then the office says, good news, you have benefits, or your plan gives you an annual amount, or you should use this before it expires. Or even, we can start today. Slow down. A dental benefit is not free money for the dentist. It is a limited resource for you as the patient. Dental bills are a major source of healthcare debt. And dental coverage does not necessarily protect people from debt, especially when annual limits apply. And that is important. Having dental coverage does not mean the senior is safe. Having an annual benefit does not mean everything is necessary. Having a treatment plan does not mean the whole plan is urgent all at once. So the senior should ask, what is urgent today? And what can wait? What are these procedure codes? What will my insurance pay? What will I owe? How much of my annual benefit will be left after this visit? Can I take the treatment plan home? Is it be all right if I get a second opinion? If a dental office tries to consume a large part of your yearly benefit at the first visit, the senior should ask why, not angrily, not rudely, clearly. Why are you trying to use so much of my annual benefit today? A question alone can and most likely will change the conversation. Next is the medical procedure case, better known as service first, coverage later. The same pattern can happen in medical care. A senior may be told they need a scan, injection, lab panel, device, therapy, procedure by an outpatient, infusion, specialist test, or follow-up service. Then comes the form, of course. The form says the patient may be responsible if insurance does not pay. Again, STOP, stop. If the office thinks insurance might not pay, the senior deserves to know why. Is the service medically necessary under the plan? Was prior authorization from my insurance company obtained? Are you in the network? Is the service covered by this diagnosis? Is the service being repeated too often on your part? And is there a less expensive coverage as an alternative? Is the statement experimental or investigational? Under what code will it be billed? What diagnosis supports it? What is the estimated cost? That's quite a list. All important to know. The senior should not be pushed into this logic. Do the service now, sign responsibility now, and just worry about coverage later. That is backwards. The senior should know the coverage risk before the service, not after the bill. Again, the senior power line is, if they know enough to ask you to accept responsibility, they know enough to explain the risk. Let's understand now that medical debt may result in a pretty bad financial trap. So therefore, it matters. Medical and dental bills can become debt. We'll say it clearly. And debt can change lives. It can affect your savings, costs of food, the way you eat, your clothing, your housing, increased stress on the family, your independence at the end as a bottom line. And the debt system can become detached from the actual care. Medical costs are most often unforeseen, and its billing is often confusing and opaque, as we've discussed here. Unpaid medical bills may be sent to third-party collections, a bunch of wonderful people. And third-party collectors may only have limited access to your records because of HIPAA and other factors. And that last point is critical. If the collector has limited access to the provider's records, then how is the senior supposed to trust a collection demand without doing verification? That supports a senior power rule. A bill is nothing but a claim. A collection notice is pressure, and neither of those two is proof. The second podcast, we were going to go quite deep into that, and it's important to understand. But in this podcast, we're talking about history here and context. The business process begins before the care. The signature may come first, the bill comes later, and the debt may come after that. The collection pressure will then begin once that's established. By the time the senior is fighting the collector, the system may already have moved through several phases. That is why your first defense must come early. It must come before the signature, before the service, and before the bill. Think about that and hold that in high regard. So, start to move towards the end of this. What about public enforcement? What is the record of the government in doing enforcement in this area? Now we need to say something carefully. This program is not saying every provider is dishonest. It is not saying every doctor is corrupt. It is not saying every dentist is trying to exploit you. It's not saying every bill is fraudulent. But it is also naive to pretend that abuse is imaginary. The public enforcement record proves otherwise. In one major example, the Department of Justice announced that universal health services and related entities agreed to pay $122 million to resolve a False Claims Act allegations involving medically unnecessary inpatient behavioral health services and illegal kickbacks. The government alleged the false claims for services that were not reasonable or medically necessary, services that failed to provide adequate and appropriate care, services not rendered, and improper or excessive lengths of stay. Department of Justice release also stated that the claims resolved by the settlement were allegations only, and that there had been no determination of liability. That last sentence matters. We should be fair. Settlements are not the same as trial findings. There's a whole new can of worms. Allegations are not convictions, okay? But the existence of public enforcement cases tells seniors something important. Billing abuse, unnecessary services, improper inducements, and revenue-driven care are not conspiracy theories. They're real. They are part of the public record. Our point is not to accuse every local office. Our point is to reject blind trust in the business process. The business process. If federal enforcement agencies take billing abuse seriously, well, guess what? Seniors should not be shamed for asking questions before they sign or pay. All right, so knowing a lot of this stuff, we come to a very interesting question. Why do seniors sign? Let's talk about why this works. Many seniors sign because they are responsible people. They want to follow rules. They respect the doctors. They do not want to be rude. They do not want to hold up the line behind them. And they do not want to look confused or being known as being difficult. And correctly so, they may be worried the doctor will not see them. They may be tired. They may be sick patients. Okay? They may be in pain. And they could be there all alone, all by themselves. They may not like tablets and website portals. They may not know even what Medicare covers, and this is very, very common. They may not understand Medicare Advantage rules, which by themselves is a whole different set of podcasts. They may not want a confrontation at the front desk. And the system takes advantage and benefits from that. Okay? A rush senior signs, a polite senior signs, an embarrassed senior signs, a frightened senior signs. A senior who does not want conflict will sign. That's not weakness. That is how this institutional pressure works. You can feel it in your chest. The person at the front desk may not be trying to harm anyone. You might not even understand what they're doing. But remember, this process can still harm you because the process moves so fast. The documents are complicated. We lack the information as patients, and the consequences are heavy. That is why Senior Power teaches seniors to slow down. You do not have to be angry. You do not have to accuse. You do not have to debate with the receptionist. You can simply say, please show me the full document before I sign. If the staff member says it's just paperwork, the senior can say, then there should be no problem showing it to me. If the document appears to shift responsibility, the senior can say, I am not a lawyer. Let me get my lawyer, advocate, or family member on the phone before I sign. That sentence changes the balance of power. It says, I am not refusing care. I am not being difficult, but I am not signing something I cannot see, cannot understand, and may later be used against me. That is not rude. That is just self-protection. I want to make some things very clear here and discuss what the podcast is not saying. Obviously, we're not saying that every doctor, dentist, receptionist, and so forth are dishonest. Absolutely not. Or acting in bad faith. Or saying that every form is improper. Or that every ABN is wrong. You know? It's not saying every out-of-network consent is abusive, and it's not saying every bill is false, or saying every denial is correct. It's not saying that. And it's not telling you, obviously, that you should refuse treatment. Not saying that we should ignore bills on the other side, deadlines, notices, collection letters, or court papers. That is not the message. Our message is the modern medical system has a strong business side, to put it nicely. That business side has documents, and those documents can matter. They can affect money, they can affect your privacy, and they can affect care. They can affect your billing protections, and can later affect how disputes are handled. They can create leverage, and seniors should not be rushed through them blindly. Our answer is not to be paranoid. Our answer is to use verification, right? Trust, but verify. The answer is not yelling. Our answer is for you to have control, which comes with having knowledge. Okay. And we don't want you to refuse legitimate care. Our answer instead is understanding what you are being asked to accept. Podcast 1 was about how today's medical business practices can put seniors at risk. In the next podcast, we will explore how to protect yourself, what rights you have, and where to get help. The third podcast will be about how we can push back. A trip to a medical office should be about care, but in modern medical systems, it can also become a business transaction before care even begins. That is our history lesson. The senior enters as a patient. The system may process that person as a signer, payer, data source, privacy subject, liability holder, and God knows what. That does not mean every provider is bad, nor that every form is improper. It does not mean the bill is wrong, but it does mean seniors cannot afford to move through the system blindly. Not anymore. Not with signatures hidden behind tablets, not with forms minimized as just paperwork, and not with financial responsibility language buried in the intake. Okay? So, what shall we do? The first rule is do not sign blind. The second rule is do not pay blind. And the third rule is make them prove that what they're asking for is correct. That is senior power. Because information plus knowledge equals our senior power. Look forward to seeing you in the next episode, and please remember to subscribe, to like us, and to notify other people that this is certainly worthwhile. Take care. Until then.